Disorders in phonation are assessed and treated in both children and adults in a variety of practice settings, using both acoustic and visual information about phonation. There are a wide variety of disorders that affect phonation, including those with neurological causes, those with structural causes in the larynx, and those related to other situations such as hearing impairment, or cases where voice quality is undesirable for some reason, such as in the case of a transsexual. Amyotrophic lateral sclerosis, or ALS, is a progressive neurological disorder that results in muscular weakness. Often this is first realized in fine motor tasks like the production of speech. Voice in people with ALS often has abnormal levels of fundamental frequency, either abnormally high or abnormally low, a reduced frequency range during connected speech, so an inability to use the voice as expressively, a smaller range for maximum phonation frequency, so if you test the limits of the person, they can't span as wide a range as you would expect, and increased levels of jitter, which is cycle-to-cycle variation in fundamental frequency. Intervention for ALS focuses on strengthening laryngeal muscles and respiration to reduce the progression of the disease. Parkinson's disease is a progressive loss of dopamine that results in muscle rigidity, slow initiation of movement, and muscular tremors. In the voice, this often results in a higher fundamental frequency, a decreased ability to vary frequency, lower intensity levels in speech, an increased dynamic range or difficulty controlling amplitude in speech, and higher levels of jitter. There's a famous example of Parkinson's disease in an actor, Michael J. Fox, and there are interview clips of him earlier in his life and now after the effects of Parkinson's, as well as the medication that affects Parkinson's disease. Treatment for Parkinson's is primarily through medication, but voice therapy that focuses on increasing loudness can be effective in reducing the changes. A unilateral paresis or paralysis, a weakness or an inability to move one of the arytenoid cartilages, causes an inability of the vocal folds to reach the midline. This results in a breathier voice with lower intensity and higher levels of jitter, and a reduced harmonic-to-noise ratio due to that increased breathiness. Treatment is primarily medical by adding bulk to the vocal fold or surgically moving the vocal fold into the midline so that the movable vocal fold can better make contact. Spasmodic dysphonia is a neurological disorder that's specific to the voice, in which the individual suffers spasms of the muscles that control the vocal folds. There is an adductor subtype, which results in laryngospasms and tight adduction of the vocal folds, which will interrupt phonation. There is an abductor subtype, which results in a more strained and breathy sounding voice due to inadequate adduction and additional effort to make adduction happen. And people sometimes have both subtypes with variation in whether there are adductor or abductor spasms. Spasmodic dysphonia results in aperiodicity in phonation, uncontrollable shifts in frequency, higher than expected variation in frequency and amplitude, as well as a lower harmonic noise ratio. Treatment for spasmodic dysphonia is primarily medical, using Botox injection to eliminate spasms in the muscles. This can result in a weak-sounding voice and also requires a re-injection every 3 to 6 months. Sometimes a surgical addition of a bridge is added to prevent a tight adduction of the vocal folds in severe cases. And the link provided on your slides has some examples of voice samples of people with different types of spasmodic dysphonia. Paradoxical vocal fold motion was mentioned in the respiration section. It's characterized by inappropriate spasms of the vocal folds during the inhalation phase of breathing. So in respiration, this results in stridor and dyspnea. However, during phonation, you can also get hoarseness, strain, breathiness, or aphonia, a loss of phonation during speech. If you measure continuous phonation, you can find higher than normal jitter and shimmer values, as well as lower than normal harmonic to noise ratio values. Stuttering involves difficulty in coordinating respiration, phonation, and articulation. Acoustically, this results in a reduced fundamental frequency range on stress in speech. Stress tends to be more monotone. In addition, stress syllables tend to be in increased duration. Observation of phonation in people who stutter show differences in the opening and closing phases compared to typical speakers. Therapy for stuttering generally involves altering the approach to speech production to try to limit the speech rate and increase control over the various speech functions. So speech sounds are intentionally prolonged, and a plan to produce speech to a predetermined rhythm may be made. Benign mucosal lesions refer to a variety of nodules, polyps, contact ulcers on the vocal folds themselves that can interfere with phonation. They can be caused by vocal abuse, such as in singers or teachers. They can also be caused by poor care for the vocal folds, inadequate hydration, for example. Additionally, it can be the result of acid reflux. If acid from the stomach escapes through both esophageal sphincters, it's going to end up affecting the larynx. In addition, you can get benign mucosal lesions from compensating for other voice disorders. If you have a voice issue that makes phonation difficult and requires extra phonation effort, that may result in contact ulcers, for example. Acoustically, we find increased jitter and shimmer, as well as decreased harmonic to noise ratio. Muscle tension dysphonia is abnormal muscular tension during phonation. This may be the result of structural abnormalities in the larynx that prompt compensatory strategies. Once a person has made compensatory strategies, if they have a nodule, for example, these muscular patterns can persist after the original cause is taken care of, so if the nodule is removed, for example. And in addition, this tension may cause additional problems with the vocal folds, such as mucosal lesions. Acoustically, people with muscle tension dysphonia have an abnormal fundamental frequency compared to typical speakers, may have breaks in phonation when phonation would otherwise typically be continuous, and have a loss of intensity with prolonged speech due to inefficient phonation. Treatment involves therapeutic training with a speech-language pathologist on relaxation of the use of the phonation muscles during speech. Person with laryngeal cancer may be left with a dysphonic voice after removal of partial or all of the larynx. In severe cases where the full larynx has been removed, there are a couple of alternatives for producing speech, either using the esophagus, similar to burping, or by inserting a valve between the trachea and the esophagus that can be used to control the flow of air for speech versus respiration. Links in the slides provide a couple of examples of this type of speech production, and you can see a proficient speaker can actually be pretty easy to understand. These alternative forms of phonation generally have a lower fundamental frequency and lower intensity than normal phonation, as well as a higher jitter and lower harmonic to noise ratio. After medical treatments for cancer, therapy involving respiration for breath support can also improve fundamental frequency and intensity in speech. Hearing impairment can have effects on the quality of phonation due to the importance of auditory feedback in controlling the voice. Deaf speakers typically have atypical variations in fundamental frequency and intensity of their speech, may have abnormal intonation contours compared to typical speakers, and may have abnormalities in vocal quality that they can't detect because they can't hear it. therapy is similar to the therapy for muscle tension dysphonia, as the issue with hearing impaired speakers is often muscular tension due to more reliance on tactile feedback while producing speech in comparison to auditory feedback, being able to hear your own speech. The link provided in the slides gives you an example of a deaf speaker. Transsexual voice refers to individuals whose gender identity is in conflict with their biological sex and who identify with the non-natal gender. This is one example where a speech-language pathologist may work therapeutically, not necessarily because of disorder, but to achieve a more appropriate or desired voice or speech pattern for some reason. In the case of transsexual voice, the goal of treatment would be to emphasize and highlight the markers of the desired gender speech. So in the case of American English speakers, a trans woman would need to work on a higher average fundamental frequency and increased breathiness in the voice, as well as a larger pitch range for speech production. A trans man would need to work on a lower average fundamental frequency and producing phonation along the full length of the vocal folds instead of leaving a space between the arytenoid cartilage to create breathiness. The link in the slides has a video example of a person who has undergone transsexual voice therapy, demonstrating their new speech production ability versus their old habitual speech production.